so I am recording this, but it's not playing up there, and I don't know why. 3, 2, 1, start. Okay, so this is where we're going to start. We're going to start on the respiratory system. And when I say respiratory system, what do you think of? Lungs. Anything else? Oxygen. How about a set of muscles that make you suck the air in and blow the air out? How about in goes the good air, out goes the bad? That's a good thing to know. All right, now some of you have probably seen this film before, and if you have, please don't speak up too much. But this is a picture of, this is a normal chest x-ray, CXR, okay? Now, tell me something that you see on that film. It's a lady, huh? Yeah. Obviously where her mind goes. What do you see? The lung? Yeah, why is that thing in the middle there? What's that? That's the heart, yeah. What else do you see in that picture? Ribs. Okay, these are ribs, right? These are this is the diaphragm here and the diaphragm there. Those are pretty normal looking. Anything else?
Spine.
What?
Spine. The spine.
The spine, yes. These are the vertebrae. And by the way, for you people that are going into X-ray, this is about a perfect exposure. You want to be able to see the spines pretty carefully, completely up here. If you've exposed the film right, you really can't make them out very well right through here. It's a matter of how much penetration you have. Okay. All right. What are these bones right here called? Clavicles. Yeah. What's this one back here called? Scapula. Why is the scapula around out to the side like that? Why isn't it? Huh? How many of you have ever had a chest x-ray done? How do they make you stand when you get your chest x-ray done? How about like this? Right? And you kind of have to drop your shoulders up against the film, so you pull your shoulders in forward, and by doing that, it pulls your scapulas around so that you don't have to go looking through the scapula when you're trying to look at this lung, okay? Because there's not much to see in the scapula, but there's oftentimes a lot to see in the lung. So yeah, that's what makes them pull out there like that. What's this down here? What's that dark area right there? What?
A stomach bubble.
A stomach bubble. That is an impending belch. Yes, it is. That's air in the stomach. You see it's below the diaphragm. Okay. What's this thing mean up here? LKB, and then that round thing. What does that mean?
The left side of the body.
L means left side of the body, yeah. Okay. How about the K8? I think that's what that is. That's the number assigned to that particular x-ray tech. In medicine and healthcare, you're going to have to sign your name to whatever you do. Your work is always going to have your name on it. And they're always going to be able to bring it back to you and say, good job. Or not so good a job. Yeah. How about this thing right here? It's kind of got a line across it. You guys probably have never seen one of those before, but if you start paying attention, what is it, Montrose? I mean, not Montiel. Montrose lady wrote the book.
It's a bubble, so you can know which way is up.
Yeah, it's exactly. It's a bubble that has some radio-opaque material in it, and what that's telling you is that this picture is taken upright. So this is an upright chest x-ray. Now, if the x-ray was taken and the patient was laying down on her side, that little thing would go this way because the fluid would drop to the bottom. Okay? All right, so that's just an x-ray marker. Not that big a deal, but yet it's something you're going to start paying attention to from now on, probably. So what are the major functions of the respiratory system? Well, we have all these things called PowerPoint slides that kind of help keep me on track. Has anybody seen my pointer clicker? My first class this morning had to find it for me 3 times. I left it somewhere. No, it's probably here. Anyway, so here they are. It provides extensive gas exchange surface between the air and the circulating blood. In other words, you bring in the air, and then there's this huge surface on the inner lining of your lungs that allow that gas to be absorbed so that you can absorb the oxygen in and you can absorb the carbon dioxide out. That may not sound quite right, but that's what I mean. Okay. All right. Number 2, it has to move the air in and out. Okay. So the respiratory system has to go pull it in and blow it out, and that involves muscles, tendons, bones, all that kind of jazz. It protects the respiratory surfaces from the outside environment. Okay, when you take a deep breath, when you take a breath in, the nose hairs in your nose start picking up the dust and stuff that you're breathing in, and it kind of keeps them from going down into your lungs. And indeed, there's all these mucous membranes back in here that any dust will stick to in your nose, and then you can kind of snort them out and swallow them or spit them out or whatever. But, you know, all of that system up in here is designed to protect and clean the air. It's also designed to warm the air, and it's also designed to humidify the air. Now, you don't really think much about your air that you breathe being humidified until you walk over to the glass and you go like that. And you think, wow, there's a lot of moisture in that air that's coming up out of your lungs, isn't there? And we would like it when we take a deep breath for the air that gets down to the bottom of our lungs to already be humidified, so we're not kind of like drying out the inside of our trachea and our lungs, right? And indeed, that's what happens in our nose a lot. We have these things called conchi. Remember those, the bones that kind of stick out into the nasal cavity there? And as the air comes by them, it causes them to swirl and doesn't just let it streamline straight through your nose. It gets all mixed up, and it goes past all that nasal mucosa, which gets it moist and also warms it. And that's why when you're out running outside in the winter, it's really a lot better for you if you breathe through your nose than if you breathe through your mouth, right? Because if you're breathing through your mouth, it's just kind of going straight down there. And look at this. And it's kind of, it hurts sometimes just breathing in straight cold air. It's not only cold, but it's also dry. Okay. Produce sounds. Wow, we're going to learn about that. And that's pretty cool. I mean, think about this for just a second. The periodic table of the elements. I just read that off that thing up there. But think what it took for me to say that and to make those noises. You probably never thought about talking other than big deal, right? But the way we talk is because we make our vocal cords vibrate. And you guys have all done that trick when you were in kids and you're in middle school and you take a piece of paper and you know, it would squeal, and the teacher would get all upset and all that stuff. Well, what you're doing is basically you're making a vocal cord out of a piece of paper, and the tighter you pull it, the higher the pitch. And the less tight you pull it, the lower the pitch. And that's what we do when we talk. We do that with our vocal cords. We want to make a high note, we pull them tight. If we want to make a low note, we cause them to relax. But the subtleties of being able to say the periodic table requires an incredible amount of adaptation of that tension that's on those vocal cords. And the fact that we can then say hello and say it rather loud and say it louder rather than or say hello. The difference between those two is the amount of air that we're blowing out past our vocal cords when we say things. So we'll come back to that. But I always think that's one of the coolest things about the respiratory system. And then it participates in the olfactory sense. What's that mean? Smell. Yeah. And we don't give a lot of time to olfaction, to smelling, but it's pretty cool. I mean, in humans, we tie olfaction to gustation. So taste and smell are both so tightly intertwined that we don't really separate them very much. When you enjoy a good meal, it's hard to separate the taste of the meal from the smells of the meal. And everybody buy that? We'll talk about those things when we get to the next chapters. All right, you've already had those. I'm sorry, I was in 2. I'm losing it. Well, that's not advancing well. I don't know what I'm doing wrong. Okay, like so many things in A&P, we have to split it up so that we can create questions. And so the book does that, and I don't usually do it, but the upper respiratory system is everything from the larynx. This is your larynx. Another name for your larynx is your voice box right here. If you put your hand, everybody grab their larynx right here. Now swallow. What happened to your larynx when you swallowed? It went up, yeah. Your voice box goes up, it hits up against the epiglottis. Remember that epiglottis thing that closes it off so that when you swallow, the food doesn't go down into your windpipe. It goes down your esophagus, which is the tube in back. So yeah, that's what the larynx is. And the larynx does go up and down when you swallow. Upper respiratory system is above the larynx, lower respiratory system is below. I'm not sure that really means anything, but I'll talk about it anyway. The respiratory tract, another way to split it up is to divide it between the conducting portion, which is the pipes that carry the air from out here all the way down to your alveoli, basically. The alveoli are the little air sacs where the actual exchange of air is going to take place. And the respiratory bronchioles, they're really alveoli mostly. There's tiny, tiny, tiny little bronchioles that have alveoli coming right off of them. I'm not sure there's much difference between those two terms, but I'm sure there is in somebody's book. The alveoli are really where the action happens. They are in the lungs, and they are where the gas exchange really takes place. I'm losing my damn brain. Okay, looky here. All right, so looking at these parts, here's the nose up here, nasal cavity. What's this bone right here called?
Hard palate.
Yeah, what's the bone name? The name of the bone is the maxilla. Yeah, up in front, because see the teeth come out of it. Remember? Okay, so there's the maxilla. It's your hard palate. You put your hand in the top of your mouth. You feel it. It's hard. That's the maxillary bone. And then if you walk your finger on back, it gets softer. That's the soft palate back there behind. Anyway, so here's the 3 conchae, the superior, middle, and inferior nasal conchae. This whole thing up here is the nasal cavity. And then it comes back here through what we call the internal nares. This is the external nares right out here that you pick through. This is your internal nares back in there. That's where it really goes back into the pharynx. The pharynx is this area of the of the respiratory tract that goes both ways. In other words, it not only carries air, but it also carries food. So when you swallow food, your food goes this way. When you breathe air, it goes this way. So the pharynx is divided into 3 parts. It's divided into the nasopharynx above here, the oropharynx, the part that's really in the mouth, the back of the mouth, the oropharynx, and then the laryngopharynx below that till it gets to the larynx. Anyway, they draw this line across here and say that's the upper respiratory system. Okay, this is the lower respiratory system. Here's the trachea. The trachea splits into the 2 main stem bronchi, the major bronchuses that go to your right and left lung, and so forth. Respiratory epithelium, you remember that from the first weeks or so of 231. What kind of epithelium lines the trachea? What? Simple? No, it's not simple. Huh? PCCE, yeah, but I don't know what those letters mean. Pseudostratified, ciliated, columnar epithelium. All right, remember that? They're pseudostratified. They look like there's more than one layer, but there's really only one. And they're ciliated, which means they have cilia on the top. They're columnar, tall cells, and it's epithelium. Well, the cool thing about this thing, this epithelium, that's what it looks like under a scanning electron microscope. That's pretty high power. Is that it has these cilia. And these cilia are really important to us because that's what cleans our air out even more. So if any air which still has crud in it gets back there into the back of our throat and starts going down, it eventually touches the wall and sticks to the wall, right? And it's covered with kind of mucousy stuff. And then there's all these cilia, and those little cilia are all working their way to push all that stuff back up. And I think they call that the pharyngeal or the tracheal elevator, where it's kind of pushing that stuff up like an elevator to get it out of your lungs. And it pushes it up to the top of your trachea, up to your mouth, basically, where you can swallow it. And it'll go down into your stomach, and you can digest it and kill all the bacteria. It won't stay in your lungs. Now, why do I tell that story? Well, I think that if you never thought about it, the thing you need to know, if you learn one thing in A&P, is that whenever you smoke a cigarette, and it doesn't matter whether it's nicotine or whether it's cannabis, when you smoke, get that smoky stuff back there in the back of your throat and going down your trachea, it causes paralysis of all of those cilia for about 12 hours. So you smoke a cigarette, and all your cilia that were doing like this, trying to push all that stuff up out of your lungs, are paralyzed for 12 hours, period. We've known that for years and years and years. So what? Right? Well, it's a big deal, because over a lifetime of smoking every day, more than 2 or 3 cigarettes, most people do, all that stuff just kind of keeps staying down there. And it's harder and harder to get it up, and that leads to destruction of your lungs. It's called COPD, which you see advertised on TV all the time. Oh, Grandpa, you're always snorting and carrying on, and well, I got COPD. And, of course, they never say, well, the reason I've got COPD is because I have 57 years of cigarette smoking. So I've got 120 pack years, which is 3 packs a day for 40 years. 120 pack years. That's another term you'll learn in medicine. And I've seen a 200. I've seen a patient that had 200 pack years of smoking. Well, that patient's cilia have never worked since they were 11 when they started smoking, So all that stuff kind of gradually builds up, and that's why these old guys, you see them, they're running around with oxygen on and all this stuff. It's a very, very slow thing. I remember on the respiratory board one time, our job was to interview these guys about this sort of stuff, and you had questions to ask them. You know, when did you start smoking? Oh, I was 11. How much you smoke? You know, oh yeah, 5 packs a day. Why do you smoke so many? Well, you know that when I was in the military, they gave them to me for free, and then I get them for $0.10 a pack on the base, you know, and it was a huge conspiracy, really, on the part of the tobacco companies to get the whole World War II generation hooked on cigarettes. They gave them away in every C ration pack. Every meal you got when you were landing at Normandy or anywhere else had cigarettes in it for free. Anyway, that's what it did. So here's that epithelium. You remember what it looked like? Kind of looks pseudo-stratified. It looks stratified, but it's really not. These are goblet cells or mucus cells. Remember them? They're the only unicellular glands in our body. One cell sized glands that make mucus. And so here's this elevator thing over here with these this mucus layer continually being washed up and then swallowed. We have a bunch of different systems that help us keep our air clean and keep our lungs clean, and we can talk about them, and we will. Here we go. One is called the mucus cells and the mucus glands. We have lots of mucus in our throat. You know, when you get a cold, you get a lot more mucus, and then you're really hocking up stuff. When it gets yellow, that's because there's a lot of white cells in there, and it's usually because you have an infection of some type. So asking the color of people's sputum is important. And these old guys would say, yeah, doc, I get up every morning and I cough. How much do you cough? He says, usually about a coffee cup and a half. And, you know, as I would try to hold myself and keep from throwing up, I would say, did you say a coffee cup and a half? Yeah, on good days, you know, on bad days it might be 3 cups, you know. I mean, and they do. They just sit around and cough all the time, and they just think it's normal, you know, but their system is trying to fight all this stuff off and clean it out. So we got all these mucus glands, these cilia. Here it is, the mucus elevator. There's a nice name for it that I've been talking about. Some stuff does get through in all of us. If it gets all the way down into our alveoli, it gets all the way down into our lungs, we luckily have these little cells called alveolar macrophages that are the last line of defense, really, and they just eat up any, they're also called dust cells, I believe. They just eat up any dust that made it all the way down into the bottom of our lungs. Up in the nose, I've already kind of talked about this. We breathe air in. Goes in through our nostrils into the nasal vestibule. Nasal hairs are in there, and they start filtering things out of the air. Nasal cavity, there's a nasal septum down the middle, and really, remember the nasal septum, what was that thing called? What was that bone called that made that happen?
The bone?
What?
The bone?
Ethmoid bone? Ethmoid bone, what is that? Wasn't that called the vertical? Yeah, the vertical plate or something.
Perpendicular.
What?
Perpendicular.
Perpendicular plate. There you go. And then above that, there was the thing that had all the holes in it. It's called the cribriform plate. Remember that, where the smelling nerves went up through? And then above that, there was another little piece of the bone that went up, kind of divided your brain, kept your brain from sloshing back and forth. It was called the, what? No, Salters is behind it. Christagalli, yeah. Weird names, but I just love them. Okay. So anyway, I think one thing that's important to know is that the only place we smell from is in the very superior part of our nose, the very top part. And it's actually the part of our nose nasal cavity that is above the superior concave. So you've got, you know, inferior concave, middle concave, superior concave. And then above that is the only area where we smell from. Okay, the olfactory area. The idea of these meatuses and these conky things are to produce air turbulence so that it warms it and humidifies it as it goes through our nose. It's the hard palate, that's the bottom, soft palate, extends on back, and then we get into the nasopharynx. As it finishes going through the nose and the nasopharynx, it enters through what we call the internal nares. It's just kind of a point on a diagram, really. The nasal mucosa is really important because of the amount that it warms and humidifies the air. You're pretty well destined to have a sore throat if you breathe through your mouth very long in the winter. If you're breathing cold air, dry air in through your throat, usually in about 20 minutes, you're going to have a flaming red throat just from it being dried out. And that's why we want to breathe through our nose when we can. I think I'll stop here. Let's go to lab. Upper respiratory tract. Because we don't really have anything to do in lab today, specifically, other than, oh, wait a minute, I got a surprise for you. A safety video. Does anybody need a lab manual? His hand went up first. I'm sorry. How could I not look at you? Oh my gosh. All right, does everybody have a card? Everybody get a card. I'll talk about it when we get over there. Okay.
Hey, Al.
Yeah. Could you give it back to me?
I'm from Pennsylvania.
Oh yeah, poor guy.
Yeah.
So, but it seems like they use a different text.
They do.
You can look at mine.
You're in deep trouble.
And you know what you can do? You go to Chap.com. You can run one. I had emailed you.
The information.
Okay, we're recording. Here we go. Okay, going back to talking about the upper respiratory system, we're kind of working our way through it kind of slowly. This is a bunch of cartilages that are in your nose, which you see right here. And you guys have probably had friends that have said to you that, oh yeah, I got in a fight and the guy really punched that guy and I broke his nose and he had to go to the doctor and they had to set his nose again. Well, I can tell you that in about 99% of the time, he didn't really break his nose. All he did was he moved a few of these cartilages out of joint, moved them out of place. And really all you do is you kind of, usually they're drunk, so you don't have to do much, but if not, you just kind of take their nose and push it back where it's supposed to be, and then fashion some kind of little plaster cast, tape it in place, and holds their nose sort of in place, but they're never going to have a beautiful nose again. But you just see there's a bunch of cartilages out here in the nose. And remember, the cartilages don't show up on x-ray, so you don't really see them if they're broken in either. This is a nice, what do we call this kind of view? Not sagittal. Coronal or frontal, yeah. So this would be a frontal view, or frontal cut, as illustrated here, also called a coronal cut up in the head. The crown, remember the thing on top of the crown? Didn't hear that story, huh? This is a nice picture. Think about this for a minute. So up here in front, you see there's these frontal sinuses. You've seen all those Dristan advertisements that have the sinuses drawn in up here that are all red and throbbing and swollen and so forth. Well, we have sinuses up in our head, and here they are on this cut. And here's the nasal cavity going through here, back in the face a little bit. And you notice here's your perpendicular plate. This is farther back. So this is actually the vomer. Remember the vomer? Just check. And here's the inferior nasal conchus. Here's the middle conchus. Here's the superior nasal conchus. And remember what I said, the olfactory area of your nasal cavity is above that superior one, so it's up in here. Then you notice that there's ethmoid air cells. Remember the ethmoid sinus? It's back there. Here's your eyeballs on either side. These are your maxillary sinuses. These are the big ones that are out here that are probably the most common ones that we get snotted up and that throb and fill with pus. And you know the reason they fill up is because there's only one little drainage hole out of them, and it's kind of up here. So it's not a good gravity draining system. But if you snort at it hard enough, you can usually empty them. Here's your hard palate right here. Here's your mouth. Here's your tongue down here. Isn't that just a great picture? God, you gotta love this stuff. Here's what do we call this view here? This is a sagittal view. And so here you're looking at it from the sagittal area, but it's kind of 3D. It's kind of deep too. So here's your three conchi up here. This is all your nasal cavity up here above. And you notice this is your external nares out here, which is basically your external nose where you enter the nasal cavity. Here's your internal nares right here, back here, which is where it goes really from nasal cavity back in here to nasal pharynx. Remember, pharynx is the dual chamber that both carries food and air. So this is nasopharynx up here. In the middle here is oropharynx. It's part mouth, oral cavity, as well as pharynx. Here's your palatine tonsil, lingual tonsils. Here's your epiglottis. This is your laryngopharynx down here, kind of below the edge of the epiglottis is laryngopharynx. And then if you go this way, you're going down in the windpipe, in the breathing tube, the trachea. And if you go back here behind, that's the esophagus. Now, just so you know, on x-rays, we very seldom see the esophagus. And the reason is the esophagus has a little tension that it's sort of under all the time. So you don't generally have any air in your esophagus. And that's a good thing, because if your esophagus were hanging open, you'd also have acid washing up into it. We call that acid reflux. We'll talk about that when we get to the digestive system. Now notice on the inside, looking at the inside of the laryngopharynx back here and then turning into the trachea, it goes through this cartilage box right here, which consists of two major cartilages. The thyroid cartilage, one you can feel up here in front, you may refer to it as the Adam's apple. Okay, it's a big cartilage in front, and then just below that is the cricoid cartilage. Now the cricoid cartilage, the thing that's cool about it is it's kind of small up front, but it's really big in back. You've got a pretty nice model of it right there, but here's an even better one right here. So here's the thyroid cartilage, big in front, little in back. Cricoid cartilage, big in back, little in front. And inside of that sort of cage created by those cartilages, or the larynx, or the vocal box, call it whatever you want, there are these vocal cords that are attached here, and this model's kind of falling apart. This one's better over here. and stretching out through there. So if we can move the epiglottis out of the way, and we can turn these are called the arytenoid cartilages in the back, and they kind of twirl like that, and you see what's happening to the vocal cords in there between, but basically they're opening up and closing back together. And if you want to make high tones, you stretch them tight and put them together. If you want to make low tones, you stretch them farther apart and relax them. So those are parts you'll need to look at as we go through on through this. But I like that picture because from the inside it just kind of looks like this. And you notice that the mucosa covers over. The first fold is called the false vocal cord or the vestibular fold. And the second one right there is the vocal fold or the vocal cord. So you'll see that as you go through your reading, and you'll see it in the models. And I'll show you some endoscopy of us looking down through the trachea with a scope, and you can see these things working and telling the patient to talk. It's kind of cool. The pharynx is this chamber that's shared by the digestive and the respiratory system, and it's divided into three parts: the nasopharynx, the oropharynx, and the laryngopharynx. And I don't think there's too much exciting here. The nasopharynx has the tonsils on the walls, and oh, how about this? The openings to the left and the right auditory tubes. Where do they go to?
Middle ear.
The middle ear. That's right. And the middle ear is full of
Air.
air. That's right. And so another name for the auditory tubes is the eustachian tubes. That's right. And these tubes here that empty into the nasopharynx back there, they give kids a lot of trouble, right? Because kids, their auditory tubes are very short and very small. They get clogged up really easy. And that's why kids, once they get clogged up, then they can't drain their inner ear, their middle ear, they fill up with pus, and they've got internal otitis, middle otitis. They've got infection inside their ear, behind their eardrum. And you end up taking them to the doctor, and they're going around with antibiotics, and then 3 weeks later it comes back again. Then they end up getting ear tubes, right, and so forth. So nasopharynx is closely tied to that whole business. These pharyngeal tonsils are really important. My granddaughter used to snore, and even when she talked, it almost sounded like she was snoring sometimes. She had a bunch of cases of tonsillitis every year, and I finally took her to the doctor, and I said, "Listen, man, take a look. This girl's got problems." And he looked in her mouth and goes, "Yeah, they're huge. We ought to do a tonsillectomy." And tonsillectomies used to be done very routinely and very randomly. I can remember when I was working in an operating room before I even went to medical school, you would see the entire family, 7 kids, all in one day scheduled to have the tonsils out. I mean, that's just the way it was done. You get a family that had good insurance, you put them all in and operated on them. But in honesty, it was just done willy-nilly. Now we only do it on people that really need it. But I can tell you that this changed her life. It changed my granddaughter's life. She now runs faster than any kid in Washington County in the 100-meter and 400-meter dash, and I'm not kidding. She sleeps all night. She never snores. She hasn't had a single ear infection or tonsillitis since she got her tonsils out. So it's a really, really big deal. I never had my tonsils out. I never really had any trouble with them. So anyway, the oropharynx is the back part of your mouth. Laryngopharynx is back there from the hyoid bone to the entrance of the larynx and the esophagus. Air flows down through the larynx. The larynx is this vocal box, and it's basically a box that's surrounded by these 2 big cartilages, the thyroid cartilage and the cricoid cartilage. The 2 of them create this solid area on which you can stretch vocal cords and thus make sounds. There's a term here that you need to understand. It's called the glottis. What is the glottis? Well, the glottis is nothing. The glottis is nothing except an opening, okay? But you need that opening to be able to breathe through. So your glottis is really important. We do have these three big cartilages. I'll show you a picture in a minute of the glottis better. You have the thyroid cartilage, which is the top big one when it sticks out in front, is the Adam's apple. The cricoid cartilage is the second one, and then there's also the epiglottis, which is hanging up here on top. And what kind of tissue is that epiglottis made of? What was that? Some kind of funny kind of cartilage called?
Same as your ear.
Same as your ear. Elastic cartilage. That's right. Okay, so here's the epiglottis right here. It's just this kind of floppy thing. You can't believe you didn't know that, can you? You guys just think you can take these tests and then forget all this crap. Ain't no way. It's not the way it works anymore. So here's the thyroid. I think I've said enough about it. There's the thyroid cartilage is just kind of sitting there, and it's held by a bunch of ligaments that connect it, you know, to the hyoid bone. You remember that one? The hyoid bone, the epiglottis, laryngeal cartilages. They're all kind of in bed together back there, with all held together. Cricoid cartilage is right below it, and it forms the main posterior part of the larynx because it's big in back. And then between, just below the cricoid cartilage is the first tracheal cartilage. So, Mr. EMT, what's a cric?
That's creating an opening for obstructed airway.
Okay.
Portion of the throat.
And where does it go? Where do you make that hole? You got somebody who's got a piece of meat stuck in their mouth, and they're dying because they can't breathe, and you're going to do an emergency slice in their throat to reestablish their airway. We call it a cricothyroidotomy. And where does it go?
Well, we would do it in the cricothyroid membrane.
Cricothyroid membrane. So between the cricoid cartilage, the lower cartilage, and the thyroid cartilage, the upper cartilage, right? You're right. That's where you'd want to put it. Let me show you a picture of that in just a second here. So I think I've said enough about these. I want to show you some pictures of some swallowing done under the microscope, not but on X-ray, barium swallowing, and how all these muscles kind of work together for you to swallow. There's also 3 pairs of smaller cartilages. These are all made of hyaline cartilage. And by the way, that's the point. All of these cartilages are hyaline cartilages, except for one, and that's the epiglottis. And the epiglottis is made of elastic cartilage. Very good. Where else do you find elastic cartilage? Here. Okay. And what's the main chemical that makes up the matrix of cartilage? No. Got collagen in it. Fibrogen, no. You guys think I know, don't you? I was asking you. Let's see. What's the main thing that makes up the matrix of bone? That's like calcium carbonate, calcium salts, right? Well, what's the main one that makes up cartilage? What? It's made by chondroblasts. Chondroitin. Chondroitin sulfate. Remember that? Huh? You don't remember that? Oh my gosh, what am I going to do? All right, here we go. So, yeah, here's your cricothyroid ligament right here. This is where you do a cric. A lot of people do it right here, actually. I can tell you that if I was doing one, I would do it below the cricoid, right there in the cricotracheal ligament, and stick a tube in. This is the disorder we're talking about is, usually you'd like to be able to fix it with an old, what do you call that thing where you squeeze somebody around the belly and Heimlich maneuver, yeah. Yeah, well, if you can't do that, then you do a crike on them, and you make a little incision here, either between the thyroid cartilage and the cricoid cartilage, or just below the cricoid, right here in the cricotracheal ligament. And below that, you see it's tracheal cartilages. Now, I will tell you that I never did one of those, but I did do tracheostomies, which we would usually come down here to the second tracheal cartilage and make an incision in it. Usually this one, and this one, we'd divide all three of them and then just kind of open them up and put a tube in through there into the trachea to breathe for somebody who was obstructed up here. And before we get to the end of all of this, remind me to tell you my story about lockjaw. What's that disease? Lockjaw? Huh? What's it called? Tetanus. Anybody ever heard of tetanus? Yeah, I treated one patient in my life for tetanus, and she couldn't open her mouth because she had lockjaw. That's the common name for it. And so we went in and did a tracheotomy on her. It was about the scariest. That's the scariest I ever was in doing surgery, because she had a husband and 3 children sitting out in the waiting room, and she was about y'all's age. And for religious reasons, she didn't believe in having tetanus shots. And she got tetanus, and I'll just tell you the story right now. It's not that long. This guy comes up to me, he's an internist out there in Dallas, and he says, Hal, I got this lady that's got tetanus. I said, bullshit. Let go of my leg. I've never heard of a patient with tetanus in my entire career. He says, no, she's got tetanus. I know she does. And I said, okay, what do you want me to do? He says, well, I need you to put an airway in her because we've got a helicopter on the way up here to get her, but they won't take her in the helicopter unless we have a tube in her throat to breathe for her. Because she's getting to where she can hardly breathe. And I said, okay. Well, I called up the OR supervisor and got an OR and had her sent down. I met the lady in the operating room. Not the best place to meet a new patient, but anyway, I said, and I said, here's what we're going to do. We're going to numb up your throat, and we're going to put a tube in your windpipe so we can breathe for you, so we can put you on the helicopter and get you the hell out of here. That's what I really wanted to say. And I said, why, by the way, why didn't you get a tetanus shot? She says, oh, I don't believe in shots. It's my religion. I said, well, what religion is that? And, they never have an answer for that. It just drives me crazy. Well, anyway, long story short, me and a nurse, lights, headlights, a whole bit, suction and everything. We went in through her neck, made an incision in these tracheal cartilages, opened it up, held it open, and put a tube in. And, oh, man, it was great because she was awake through the whole thing. We could talk to her because we couldn't put her to sleep, because once we put her to sleep, we had no airway. Yeah. Well, anyway, so we got it all taped in and got all ready to go, got her on the helicopter and waved goodbyes. The helicopter took off. And like usual, whenever we sent patients to the University of Oregon Health Sciences Center, we never heard another damn word about them. They're like, oh, you guys are just country doctors out there. What the hell do you know? You don't even need to know what we do in here, which is kind of the way it worked. I'm sorry to say it like that, but that's kind of the way it worked. 4 years later, I was standing in the meat aisle in Fred Meyer's, and I was looking at the steaks. And this lady comes up to me and she says, aren't you Dr. Sessions? I said, yes, ma'am, I am. I took my name tag here. No. I said, yeah, I am. She says, well, I'm the tetanus lady. And I said, you survived. She said, yeah, I was 128 days on the ventilator, 4 months on a ventilator until she recovered enough from tetanus toxin.
How did it not spread everywhere?
It spread everywhere.
Yeah.
You know, they just kept her paralyzed and paralyzed in order so that they could. Yeah, I think it's a pretty terrible thing. But the point, you know, now that I'm older and I'm not scared of doing a trach on her, I thought to myself, how much does a tetanus shot cost? It cost 50 cents. For the cost of that one case of tetanus, now time in an ICU on a ventilator is about $10,000 to $15,000 a day. For the cost of that one case of tetanus, we could have given a tetanus shot to every single person in the state of Oregon. And at some point, you have to realize that she never paid a penny of her hospital bill. I mean, Christ, they were just they were real nice country folks that lived out in the country and, you know, probably hunted and raised most of their own food themselves out there south of the Dalles. And, you know, so she probably got a, you know, $4 or $5 million bill, which the state just had to eat. So that meant that all of us had to eat that bill. And how do you balance those sort of things? You know, these are tough decisions. And as you become more and more into the medical field, you'll realize that, you know, the sympathy movie I showed you, it's for real. We have to take care of each other. And we have to take care of that lady. And we did, but yet, damn it, you should have had a tetanus shot. And when I saw her in Fred Meyer after I had this conversation with her, I said, let me ask you one other question. Did you get your kids a tetanus shot? Oh, yeah, they've all had tetanus shots. I said, thank you. All right, enough of that story.
When did there's a anti-venom, isn't there, for the tetanus?
There isn't
now?
There's not an anti-venom.
Or
There's
not, it's not.
tetanus toxoid is what you can,
Give them now.
yeah. But it's still, once the disease is established,
Doesn't matter.
it doesn't help much. No, I don't think I'd like to see there'd be an anti-venom, that'd be great. We'd have given it to her, but we didn't have it. You remember that muscle chapter we went through a few chapters? You remember that stuff about tetanus? Oh, okay, just checking. All right, so here's what it looks like from the side. Here's the thyroid cartilage up here on top. Here's the cricoid cartilage below it. Here's these arytenoid cartilages, and the arytenoid cartilages are really the ones I'd like you to know a little bit about because they're the ones that are attached to the vocal cords. And so the arytenoid cartilages are the ones that kind of rotate. And as they rotate, they change the tension and the location of the vocal cords and make them tighter or make them closer together. Okay? So that's the arytenoid cartilages here. Corniculate, they're not very important. They're just real tiny little things that hang on the top. And here's your tracheal rings. Remember those tracheal rings? It was the third day of 231. What kind of cartilage are they made out of? Oh, sure. Everything's hyaline. Except for the two we've talked about. I don't think you won't see that on a quiz sometimes. Corniculate and arytenoid cartilage function in opening and closing the glottis and the production of sound. Lots of ligaments up here. I don't think all you need to know is the false vocal cords are called the vestibular ligaments. The vocal cords, the ones that actually vibrate when you talk, are the vocal ligaments. And I think we can do away with that. How do we make sound? I've kind of already told you. We make sound by letting air pass out through our trachea and through our larynx, and it vibrates over the edges. It makes the vocal cords vibrate, and that's what makes sounds. Now, that doesn't, just because it makes sounds, doesn't really explain what speech is. Because a lot of making speech is made by our mouths and our tongues, and a lot of the sound is made by letting the air pass over other things and controlling it. So here's a couple of terms that you ought to know. One is called phonation. Phonation is making sound at the larynx with those vibrating vocal cords like we've talked about. But articulation is really what speech is about, being able to articulate the words properly. And for me to do that, I've got to have my tongue, I've got to have my mouth, I've got to have my lips so I can open things and make P's, things like that. So a lot of our voice is not really straight from our vocal cords. This is a picture of the vocal cords from the top through a scope, and we're looking at it. So this is the posterior side up here, and this is the anterior side down here. How do you know that? Well, you know it because you know the epiglottis is on the front. Okay, the epiglottis is going to be on the front. So here's the epiglottis right here. Here's the epiglottis here and here. These little things you see right here, what are they? Taste buds. That's right. You remember those circumvallate taste buds? Wow, here they are again. It's like a review every day. Anyway, you look down through here, and this opening area that I told you before, that's the glottis. And it's not anything, it's not a structure, it's just the opening. The opening is the glottis. So you can see it here, and here you see the glottis is closed. And when people talk, when I'm talking right now, believe me, I'm not letting much air escape. And that's why I can talk for a minute without getting a breath, really, because we don't really use much air. And the reason we don't is because our glottis is so closed anytime we are talking, because it has to be to make those things vibrate. So there you have it. These are the vocal folds. The glottis is in between. Just above that, you can see right here is that vestibular fold, which is kind of the false vocal cord, which they're just illustrating it out here on this picture. I think, we've talked about these words. I think I have talked about intrinsic and extrinsic. What's an intrinsic muscle of the larynx? What would an intrinsic muscle be? Yeah, it would be a muscle that's actually inside the larynx. So it might be one of those little muscles that you see that are inside here that are illustrated here, and their only job is just to move these cartilages, rotate the cartilages a little bit. Those are all intrinsic. They're within the larynx itself. But then we have other muscles that are extrinsic. And a minute ago, when I had you put your fingers on your larynx and swallow, those are extrinsic muscles because they're muscles that they're not within the larynx, they're outside of it. They move the whole larynx around. So extrinsic muscles. Isn't that interesting? Trachea, going on downstream here, the trachea is called the windpipe. It goes from the cricoid cartilage up here, and it comes on down here until it splits. The place where it splits is called the carina. The carina is basically the crotch of the trachea. It branches into two pulmonary bronchi. Don't get too hung up on the names. The right and left one. The right one goes to the right lung. The left one goes to the left lung. Some people call these primary bronchi. I just main stem bronchi is what we used to call them. The submucosa is right below the mucosa. Lots of mucus glands in the trachea, so that you got tracheitis. You get a lot of mucus created in your throat. You remember these pictures? I would recommend you review these slides. They're in the box over there. And because they're so cool, because you can look at all these different things that you remember now. For example, here's the trachea, right? The lumen of the trachea. And the inner lining of that is respiratory epithelium, which is what kind of epithelium? PCCE, right? And then there's this cartilage here, which is what kind of cartilage? Hyaline. And then in front of the trachea, there's this great big organ that's really bloody and has all these wonderful little follicles in it. And all the follicles are lined with cells around the follicles. And those cells are called, they're thyroid cells, called follicular cells. Remember that? What kind of epithelium are they? Simple cuboidal. Little squares, right? Pull it out and look at it. You'll never forget it again. Across the back here, there's this muscle called the trachealis muscle. And the thing that's really cool about looking at the trachea is you know that right behind the trachea there's another tube, right? And sure enough, there it is. It's called the esophagus. And you remember what kind of epithelium it's lined with, I'm sure. And you know that it's got smooth muscle in it, right? And then right out here to the side, there's a nice round thing over there. Feel your neck, feel your pulse, carotid artery, right? And on the other side, on this cut here, you see some big blood vessels that are basically the jugular vein on the other side. The veins, remember, are kind of odd shaped. They're not nice and round like the arteries are. Coming around, guys. It's closing in on the circle of life here. All right, the tracheal cartilages, there's about 15 or 20 of them. They have this little ligament called and the trachealis muscle across the back. Why do we have that trachealis muscle? Why don't we just have tracheal cartilages that go all the way around? Remember this? Let's go back. Well, the real reason is that if we didn't have the trachealis muscle, we couldn't swallow a big bite of meat, okay? Because if this cartilage went all the way around here, then when we tried to swallow a big bite of meat, it couldn't go down. But because the back of the trachea here is pliable and soft, the esophagus can get a lot bigger and actually stick out here into the trachea for a second or so while a big bite of food or a piece of meat goes by. Wow, I never thought about that. Okay, let's talk about these bronchuses for just a minute. Right and left main primary bronchi, you can call them whatever you like as far as I'm concerned. The carina is an important thing because whenever you look at an x-ray of a patient that's got a tube in their throat, you always want to look for where the carina is. And you can usually see it on the x-ray. And the reason that's important is you don't want the tube that you put in the windpipe up here to go down into the right mainstem bronchus. You want it to stop about 2 centimeters above the carina so that when you're breathing the patient through that bag up there that's connected, it's blowing up both of their lungs, not just one of them, okay? So the carina is an important concept and an important thing to be able to see. In general, the right pulmonary bronchus is larger in diameter than the left, and it's also on more of a straight line. Now, why is that important? Well, let's look here at this picture for just a second, and let me tell you a story. So here's the way it fits right in you right here. And the thing you notice is that the one on the right is actually bigger around than the one on the left. But the main thing is the one on the right kind of goes more straight down, whereas the one on the left kind of makes more of a hook to turn over here to the left. And the reason that's important is that probably 95% of all the cases of what we call aspiration pneumonia, and most people that get aspiration pneumonia are drunk, or on drugs or something, and they've vomited or they've swallowed something, and it goes down in their trachea without them really being able to control it. And when it does, it almost always goes down the right side. And those people almost always get right lower lobe pneumonia. In fact, if you have right lower lobe pneumonia in this part of your lung, you can almost say, oh yeah, that's aspiration pneumonia. They aspirated something down there. So when kids swallow beans, they almost always go down there. When, anything that goes down, generally goes down on the right side. Now, obviously, if you're laying on your side or something, it wouldn't, but most of the time it does. So that's a pretty important concept right there at the very bottom, where it says the right primary bronchus is larger than the left and it descends at a steeper angle. It's going more straight down. That makes sense? Okay, we're going to quit right here on the primary bronchus. Let me just give you one last concept to take with you. You ought to try to read a little farther than we've gotten. Is that as the trachea, you see, has those big cartilaginous rings in it, a lot of cartilage in it. And then the tubes start branching and getting smaller and smaller. As they branch more and branch more, they also have less and less cartilage in them. They have less cartilage to kind of hold them open, and they have more and more muscle, so that by the time you get down to the little bronchioles, they don't have any cartilage and they have lots of muscle. Now, what disease do you think that might influence? I bet you know the answer. What? You're thinking? Huh? Asthma. Right. What's asthma? It's just overactivity of all those muscles down there that are clamping down and keeping people from breathing right. And they affect not the big blood vessels, not the big tubes, not the trachea, but the little bitty ones as they get down farther. Because there's no cartilage to hold them open. There's just muscle. Okay. See you Thursday. Okay, now is everybody in the class that needs to get in? Do I need to do any more paperwork? I guess I need you.
Yeah,
Do something for
G
you.
number, right?
Yes, I do. That's what I need is G numbers. Let me just start a list right here.
And my number is G00220586.
Okay.
All right, thank you.
You bet. You get to keep that.
Yeah, my G number is 03.
03.
Yeah, 072808.
Slow down.
03 07 2808.
Okay.
Jesslyn Nam.
Sally.
No, Jesslyn.
Jesslyn.
Nam.
Yeah. Okay.
Okay.
Anybody else need a slot? Okay. Yes, ma'am.
Physio X with Melissa.
Yeah.
Where can I meet her again?
Well, she's around here. In fact, she's there now. She's just through that door, but I just asked her. She doesn't have any printed up yet, so
Okay.
by Thursday or certainly by next week, she'll have some generated.
Are they papers or is it a
No, it's a contact. It's a CD.
Oh, okay.
Yeah.
Oh, it's a CD for physio.
You can actually.
Maybe I'll touch base with
Did
her.
you buy a book?
I was gonna get the book from you.
Oh, that's right.
The book, can we have the book from the, because I have a last year book,
Mhm.
can we use this book?
Once you sign up, you get a code number
Oh,
when
in
you
the
buy a
book.
book.
Okay.
And then it gives you a year's access to the website, and the company website has PhysioX on it.
Okay.
So there's lots of ways to get it, but the cheapest is to get us to get you one from
I was going to
Melissa.
say, now, would you have to go to Melissa on Tuesday to get that?
You know, she's kind of in and out around here. That's a good time to get her.
Or are any of the open
I
labs?
forgot to mention this. she's actually, this is the first term she's ever done this, but they hired her to work in the tutoring center
Yeah.
these hours. And the tutoring center, I think, is right up here. So you can go up there, and there it is, right there, Building 7, 218A.
Okay. So she'll be there
You
tomorrow.
can meet with her.
according
Yeah.
to that.
Yeah.
Now, do I need to put my name on here? I went over and the guy said he put the hold off, so or not hold or whatever the make.
So are you in the class? Have you been registered?
I was supposed to try again, so I can try again right now.
Yeah, why don't you try right now, and if not, I will put in, because see, once the first day of class arrives, then we have to put in another whole, a late ad, I think they call it.
Oh, we don't want to do that. We'll try to make this work.
Well, it'll definitely take one. It'll take a late ad override to get you in.
Oh, okay. Like I said, I was just talking to the guy, and he took all my
Stuff.
and then because I should have graduated last term, but I needed to pick up Bio 213 and this class. These
Yeah.
are my two hold-offs to get me gone over to PSU. I just want to go into registering. Why is this like? I've never seen this page before. I'm totally lost on it.
Yeah, it's an outage. It says C.
Oh, so it's,
PCC is experiencing an outage. So there's nothing I'm going to be able to do or you're going to be able to do right now. So here's what you should do. Give me your name and your G number.
Camden, K-A-M,
Yeah.
Leda, L-A-Y-D-A,
And your G number is?
03.
Huh?
0368785.
Okay, 0368
0368785.
858. You need to look it up.
And I was looking at the keypad right here.
Yeah, I hear you. Okay. All right. So, just send me an email. If you can't get in now, based on whatever he's done, you call me and tell me what you need.
I think I'm actually registered. They took the
Well,
hold off the lecture, but not off the lab.
Okay.
So I'm like halfway registered in
that's-
between.
yeah.
It's a
That's like